Welcome to the Critical Care Obstetrics Podcast. I'm Suzanne McMurtry Baird, the Nursing Director at Clinical Concepts in Obstetrics, and I'm with my partner today, Dr. Stephanie Martin, our Medical Director at Clinical Concepts in Obstetrics. Today, we are going to talk about having a patient in the adult emergency department who has experienced minor trauma. This can affect all of us, no matter where we work, level 1 to level 4. And now we have this patient in an off-service unit receiving care, getting cleared by the emergency department or the trauma team, depending upon the hospital where you work, and she's pregnant. What is your system? What is your process? How do you get involved in managing that patient? And again, we have listeners from emergency departments, we have listeners from other units, and we have listeners from OB. So everybody that's listening is going to have some different perspective in this. So let's get started and talk about what some of those issues may, come up with that we may have in those departments. So Stephanie.
I think the interesting thing about trauma, and particularly apparently minor trauma in the obstetric patient, is that it can seem quite benign and low risk when in fact it's extremely high risk. Yeah. And this is, and to be clear, we're really talking about beyond the first trimester. We're really talking about, the middle to later stages of pregnancy, really kind of past the point of viability. Because in the first trimester, the fetus is fairly protected and we're not really worried about this. So we're really talking more about as the pregnancy gets a little bit more advanced, but maybe not as far advanced as you think. So like, for example, let's say we've got a patient who's, 30 weeks or 32 weeks gestation, and she's in she's rear-ended. She's the restrained driver. There were no airbags deployed. Very, very minimal damage on the car. Someone, hits her from behind while she stopped at a stoplight or whatever. That's a pretty classic situation. She may be evaluated by EMT at the scene and brought into the hospital, or show up on her own just because she's worried about the baby or something. We've heard story after story where patients are discouraged from going into the hospital because there's no visible injuries and they're, but every patient who has a minor trauma in pregnancy needs to be seen promptly, because the risk exists, no matter how the mom feels.
Yeah, because sometimes I think it's just in the term minor. Mm-hmm. That minor may not be minor, depending upon, what has occurred. And depending, like you said, on the gestational age and how protected, what happened. And sometimes patients may not have a clear picture of what happened.
Right. Well, and the thing is, we're saying it's minor to mom.
Right.
But not minor to the baby. Like, she doesn't have any broken bones. She doesn't have any visible bruising. It's not unusual to hear a story like this. Well, the patient came in to the emergency department. She was 30 weeks gestation and she fell getting out of the bathtub, but there was no abdominal trauma. Not relevant. Doesn't matter. She fell. That's all that matters.
Right. Falls are a huge issue for minor trauma and cannot be so minor for the fetus and the placenta. So, and that's hidden risk.
Falls might also be code for domestic violence. A patient may not be willing to say what's happening, and she may come in complaining that she fell, but she might not have fallen. She might have been hit. She might have been kicked. She might have been pushed. Who the heck knows? So we just can't minimize the potential risk to the fetus, which we're going to get into.
Right. And I think the other issue is this is minor for the emergency department, right?
Yes.
Sometimes, if they see trauma, they see trauma,
Like her limbs are attached.
Right. In her head, or she doesn't have something coming out of her head. This is to them, it's just minor trauma. And they may think this is, not as a big deal, but,
and they're
it
correct
could be a really big
for
deal.
mom.
Right. Yeah. Yeah. For the fetus, not so much.
So maybe this is a good time to explain why it's such a big deal to the fetus before we get into the
Yeah.
logistics of how to handle it. So what we're really talking about is abruption, okay, which is, for any non-OB people listening, it's an abruption is a separation of the placenta from the uterine wall. So I think of it like this is kind of gross, but we're all medical, right? It's like a scab, okay? If you pick a scab before it's ready to just fall off and come off, it's going to bleed at that site because it's integrated closely with the skin. So you can't pick a scab off too soon and not expect bleeding to happen. And an abruption is like that scab lifting away from the skin too soon. It's going to bleed where that lift occurred. Whereas at term, they deliver their baby and the placenta just pops out like no big deal and stops bleeding pretty quickly, right? And so it's kind of a weird, gross, cool analogy. So in trauma, when you have any kind of an acceleration, deceleration, meaning this heavy uterus full of baby and water, right, gets pushed forward. Okay, so a sudden stop.
Or down.
Or down or sideways or whatever. It just gets moved quickly. Then it's going to fly forward and you're going to get kind of this rebound effect, back and forth until. Now, that movement does two things. One, you have a shearing type of effect because the muscle is moving, but the uterus is not. So this interface is sliding between placenta and uterus, and that can create separation and bleeding behind it. The other thing is that water is heavy and it creates a suction type of effect. It'll just kind of suck the placenta forward with it. And all of those things contribute to that disruption between the placenta and the uterus that has nothing to do with how the patient's, whether or not the significance of the patient's injury. So the absence of maternal injury does not mean there's no abruption, unfortunately.
Right. And not only does that abruption, cause that bleeding, mom during pregnancy has increased blood volume.
Yep.
Increased red cells. Mm-hmm. And that can mask the effects of that abruption. It can mask a massive amount of bleeding that you're not seeing because it's not coming out. It's concealed. It's behind usually. So you are then, it still seems minor, right? And when you draw labs on that patient, you may not detect any immediate blood loss that is severe enough to become worried unless you're looking at it in an obstetrics lens. And same thing with clotting factors are not going to change immediately. These patients who are pregnant have increased clotting factors as well. So their fibrinogen, unless you know pregnancy values, you are not going to detect a lowered fibrinogen in a pregnant patient if you're using non-pregnant values, because we know fibrinogen is increased in pregnancy to 400 to 700 milligrams per deciliter. Now we have a patient who is showing in the normal range of around 200 to 400, and you may not detect that she's had bleeding, and that patient could then be, again, considered normal, and she's actually abnormal for a pregnant patient.
Yeah, so all of this leads to, so when you have an abruption, the abruption can be very, very small. It can be very, very large. And, there are things you can do to try to understand if, how big the abruption is. But if you don't even consider it as a possibility because you think she's had minor trauma, you will never detect it until something bad happens. So the bleeding can be massive inside the uterus and concealed in the uterus. So you're not going to get peritoneal signs. You may or may not have vaginal bleeding. The absence of vaginal bleeding does not mean absence of abruption. It means absence of blood escaping the uterus. But that doesn't mean that there's not blood in the uterus. Right. And you can evaluate for an abruption in a number of ways. But first, which we'll talk about in a little bit, but first you have to even consider the possibility that an abruption exists and she can be bleeding and you can be having fetal and maternal compromise right under your nose and you won't even know it unless you look for it. So if you let that patient sit in the ED for 4 or 5 hours while she's getting cleared from her minor car accident, before getting OB involved or evaluating that baby, then that's a risk for the patient, for you, for the facility, because bad things can be happening in that time frame.
So key point number 1, patient hits the door in the emergency department. Who are you going to call?
Yes.
OB. OB must evaluate that patient early.
Yes.
And be involved in the care. That, again, looks different in different places.
You have to have a process. You guys have to be thinking about, if a pregnant patient comes to my ED, and what happens to her, and how quickly, and how and when do we get OB involved? I mean, because sometimes it's more appropriate for the evaluation to occur up in the OB triage, or maybe the OB ED if your facility has one. And sometimes it's more appropriate for them to be in the ED. Like if she's got an open fracture or, a sucking chest wound, and she's clearly got major trauma, she doesn't need to be in OB triage. Ain't nobody wanting her up there. That's where she needs to be, is the ED. But that doesn't mean that we postpone. It's all happening simultaneously, mom and baby, not mom first, then baby later.
I agree. And, for those of you who work in a trauma center, you're like, yeah, we know that, right? Again, but that, again, looks different in different places. And you may not even have an OB physician or midwife in-house, so at some spots. So that has to be a separate process of how you call somebody in to get this patient. But, again, also limited staffing in some rural facilities, especially, you may have 1 or 2 nurses available to go to the emergency department to monitor the fetus if the fetus is viable. Or does the patient just go ahead and come up to your unit?
No, I worked with one facility or a system at one point in my career where we had, there were multiple hospitals in the system, and not all the hospitals did deliveries or had obstetric care. And there was one, facility that was very well known in the community that stopped doing OB care, but still had a very high level trauma center. And so it was not unusual for a pregnant patient to present. Of course, EMS knew not to take the pregnant patient there, but patients bring themselves to hospitals all the time that don't provide their services. And so, we had to develop processes for how do we deal with a pregnant patient who presents for a trauma evaluation with no obstetric services. So that does look different everywhere because everybody has different resources available. And, geography can play a key, weather can be an issue, all those things. So, but you need to be thinking about how this happened, and you can't assume that everybody knows, because we have been to too many places and we know that that's not the case. And I don't ever like hearing, well, when I'm on call, this is how I do it, or this is how I handle it. No, it's how is it handled in your facility?
Right. And make sure everybody knows about it. So key number 1, again, what is your process? What is your system at your particular facility of how OB is going to become involved early and often? Patient hits the door. Who are you going to call? Not Ghostbusters, but who are you going to call in OB and how? Who, when, where, how? All of those things need to be answered. Okay. So now
before we move on, this is where simulation comes in.
Oh, yeah.
Take a case that a patient you've actually had where you thought things might have been a little bit smoother, and run through it and talk about what do we want to have happen? How could we have made this go smoother? You can even do a tabletop sim where you get the stakeholders in the room and work through the processes before you create a policy or an algorithm about how it's going to work.
That gives you the ability to figure out how you want it to look.
Right. And
instead
if it doesn't
of somebody telling you how it's going to work, right?
And then if it doesn't work perfectly, you modify it.
Exactly.
But you need a written process that all the key stakeholders have participated in creating and that you've worked through so that everybody is an understanding. You don't have to keep it in your head all the time. You just have to go, oh, we have a process for this. Let me look it up.
So key point number 2
Yes.
What is your initial assessment and triage going to look like for this patient? And for the mom, let's start with the mom before we get into the fetal assessment. What are some of the key points that you think that we need to outline for the team? Again, because you're the OB clinician, let's say, how are you going to work with the ED on what this patient needs for assessment? Say, let's start with vital signs. Imagine me bringing that up, right?
Love me a good set of vital signs.
I know. So, again, what's normal for pregnancy? A lot of clinicians out there think, well, her pressure goes down in the second trimester. So if she's hypotensive, that won't really matter, right? That's not true.
This is where we love us a mean arterial pressure.
We love us some mean arterial pressure, and you're going to want to make sure that she's got at least 65 millimeters of mercury mean arterial pressure going, because don't get into that lull of that pregnancy, decreases blood pressure in the second trimester, normalizes in the third.
MAPs are typically in the low to mid 80s throughout pregnancy, and they don't change in pregnancy. So systolic blood pressure can lower, but MAPs stay the same. So your MAP is typically in the low to mid 80s during all stages of pregnancy. That it just doesn't change significantly. So you can feel real comfortable with that. And if you've got a MAP that's decreasing, particularly if you're trending it, she's losing volume. Right. By the time your patient becomes hypotensive, she's lost a minimum of 1,500 and probably more like 2 liters of blood.
Late sign.
Period. That's very late.
Right.
So even if you don't see it, it's happening.
Yes. Same thing with heart rate.
Yep.
I think here is an opportunity of where you'll see some normalization of deviance. The patient is tachycardic. And you're thinking, well, she just had a car wreck, or she just fell. She's upset. She's now been brought into the ED. She's in an unfamiliar environment. Family may or may not be with her. That can be normalized. Tachycardia, sign of bleeding.
Yep. Tachycardia is not normal.
Not normal. It's not because she's anxious. Okay? Until proven otherwise, it's hemorrhage. Until proven otherwise. So what goes with that heart rate? Respiratory rate. Okay. Going to go up if she's hemorrhaging. Okay. So there's our vital signs. Temp, I'm not as concerned about because this not related, right? Unless it's cold outside. And let's say she fell on ice and she was there and struggling to get up. That's completely different scenario than what we're dealing with. Okay, so we got our vital signs. What else are we going to look for the mom?
Well, first of all, we're going to make sure that it really was a minor traumatic event. We're going to do a complete assessment of mom, your normal head-to-toe assessment of mom, but simultaneously with the fetal assessment, which we're going to be talking about. And you need to do some baseline labs. So the key labs that need to be done in evaluating a patient who has experienced a traumatic event. Number one, you need a CBC because you need to know what her hemoglobin and platelets are more as a baseline than as a sign of, is she currently bleeding? If your patient your patient can be having massive hemorrhage and have a normal hemoglobin. So you're going to be relying on your other assessment before the hemoglobin. If she's anemic, that's a very late sign of hemorrhage. Okay, because she'd be bleeding whole blood, and it's going to take a while for that to normalize and correct and be actually reflective of what's going on. Second is you need a blood type, because if she's Rh negative, you're going to give her RhoGAM regardless of, unless she has already had RhoGAM recently, you're going to be giving this patient RhoGAM. So you need a blood type in all these situations. And then the other piece that you need is a fibrinogen level. Now, you can order a whole bunch of other labs if you want. They're fine, but they're not essential. These are the 3 essentials, because fibrinogen is going to tell you if you have consumption of clotting factors, fibrinogen, and that you need to be suspicious of an abruption, even if the clinical picture doesn't tell you that she's acutely hemorrhaging. Because as Suzanne said before, those fibrinogen levels, if they're in the normal range on the lab, that's a red flag.
Right. And I think that our ED colleagues would possibly not draw a fibrinogen and draw a D-dimer.
Yeah, don't ever draw a
trauma.
D-dimer in a patient.
I know. Don't you think? I mean, I think that is a
100%.
difference in
Yes.
in obstetrics and ED here, is that they would draw a D-dimer versus we would draw a fibrinogen, because D-dimers are always going to be elevated in pregnancy.
Always. Or they draw a DIC panel, which is
Right.
D-dimer, PT, PTT, INR, maybe fibrinogen. The only thing that matters is fibrinogen. Okay, your PTT is not going to be abnormal if you have normal fibrinogen. So fibrinogen is really all that matters. So you can do a DIC panel if you can't remember what to do, but if it doesn't have a fibrinogen level on it, it's useless.
And PT and PTT are not going to be elevated until your fibrinogen is way low.
Very low.
Yeah.
Less than 100.
Yeah. So if you're waiting for that to be abnormal, you're way behind.
Yes, way behind.
Any
other labs that you would do?
Nope. So I mean, I think it could be very simple. I mean, instead of overcomplicating things, and depending upon her trauma, right?
Yeah. This is probably a good time to mention Kleihare-Betke testing.
Yeah.
Okay. Good. So a lot of you are probably screaming, going, Kleihare-Betke, Kleihare-Betke.
Yes.
Okay. For those of you who don't know what a Kleihare-Betke is, it's a really cool, actually. It's a blood test where we draw blood on mom, and mom's red blood cells do not have a nucleus. Fetal red blood cells have a nucleus. And so you can stain that and then look at it under a microscope and determine what percentage of mom's blood is actually fetal red blood cells and not maternal. And so using that, you can take estimates of mom's blood volume and estimates of baby's blood volume and do a calculation. The lab does it for you these days. I used to have to do it myself as a fellow and a resident. But the lab will tell you, based on this, we think that X% of the mom's blood is actually fetal, and that translates to X cc's. Okay. A term baby has less blood than a can of Coke. I'm sorry, Diet Coke.
I knew you'd say that.
So babies don't have a lot of blood. Okay. They're small. They're little creatures. So, a term baby is going to have, 300, 350 cc's of blood, something in that range. Okay. That's not a lot of blood to lose. So if the Kleihare-Betke comes back and says, we estimate that there's 100 cc's of blood in mom that's from baby, that's a third of that baby's blood volume, right? So you'd think that makes sense, that we'd be like, oh my God, that's super important. We got to know this.
Yeah.
But there's some pitfalls. First of all, it's an inexact science. Okay. Second of all, exchange of blood, baby's blood getting into mom's circulation, is not a rare occurrence. Okay. This is why we give RhoGAM before she delivers. Third, it doesn't guide your clinical management. It really has very little to no role in the clinical management of the patient. The major role for a Kleihare-Betke is to determine if they need more than one vial of RhoGAM. That's it. Okay. Because and the data support this, because any patient whose baby is anemic enough to require a fetal transfusion, because that's what we're talking about, transfusing blood to this baby that has become anemic from trauma, that's apparent on the fetal heart rate trace.
Right.
So it's all going to come down to what you're tracing. If your tracing is looking good with you've got moderate variability X cells, no D cells, no sinusoidal pattern, I know everything I need to know about this baby. I don't need a Kleihare-Betke to tell me otherwise. So I don't recommend Kleihare-Betkes.
Right.
Unless they're Rh negative.
So we've got the mom assessment pretty much covered, don't you think?
Yeah.
And now, and I think we're starting to get into the fetal assessment.
Now it's about baby, yeah.
And it's and the only way we're going to know that is to have, again, OB involved and have a fetal monitor in wherever that patient is. Mm-hmm. And to do fetal monitoring. I know. And they get a lot of attention when they come into the emergency room, right?
What is that? That's only second to a warmer, a baby.
Yeah. Yeah, exactly. You got a newborn warmer outside the door, then that gets freak. So yeah, you're going to have to bring the fetal monitor to the ED. And I haven't seen an ED that has one just sitting down there. They're too expensive. And so if you've got a pregnancy that's viable, Then you're going to do fetal monitoring, and you're going to be monitoring for uterine contractions.
Mm-hmm.
And you're going to be then looking at the fetal response to the uterine contractions. And we're doing really two things. Fetal monitoring is a screening tool, and we're looking at fetal oxygenation at the time of observation. That's the purpose of fetal monitoring. So we're looking for that moderate variability and or accelerations of the fetal heart rate. If we're looking at a preterm gestation, then we're going to define accelerations differently, a 10 by 10. But if we've got a fetus that is 32 weeks or greater, then we're going to be looking at those 15 by 15 acceleration pattern. And then again, the response, if the patient's having any uterine contractions, how is the fetus responding to those uterine contractions? We're going to make sure that the patient does not have late decelerations, and that to do that, we have to position the patient correctly. So again, if the patient is flat on her back and she's on a neck board, cervical spine collar, we're going to still have to tilt that board and tilt the patient to get the patient off of the vena cava so we can perfuse the uterus correctly, because she may have decelerations, especially late decelerations, if she is laying flat on her back. So that's key.
The alternative to that is somebody standing at the bedside and manually moving the uterus. So in some of these situations, there's so much going on that you just need to stand there and physically, like I always kind of joke, no OB is afraid to manhandle a uterus. Like you just gotta, get it off the spine, off the vena cava and aorta.
Right. So we're looking for that. We're looking for a baseline rate.
Mm-hmm.
Normal baseline rate of 110 to 160. We're then looking for sinusoidal baseline. Like Stephanie said, that would be indicative of fetal maternal hemorrhage. Mm-hmm. And then we're looking also for any kind of fetal arrhythmia. Okay. I had a fetal arrhythmia. I was a minor trauma patient in my last pregnancy with my third son. And it was a rollover.
That was not minor.
Well, it ended up being minor, but it was you
were not majorly injured, but the mechanism of that accident was not minor.
No, it wasn't. But it ended up being minor for me and my fetus, now named Luke, who's a college grad. But it was scary. It was. I can go into that later, but he had a fetal arrhythmia because of my adrenaline release. Mm-hmm. And he had it for 24 hours. So, so those are the key things that we're looking at: baseline rate, baseline variability, presence of accelerations, presence of decelerations, making sure there's no sinusoidal pattern, and making sure there's no fetal arrhythmia. Okay. Yes. That's your fetal monitoring. And who does it? OB.
Yes. And it needs to start as soon as, very soon after the patient arrives in the ED. You can't postpone this. Okay. This is not a patient who sits in the waiting room to be roomed because she appears well. That's not the situation here. Okay.
And I just want to also shout out that if you are working in a facility where you do not have a physician or midwife present in the unit that can come see that patient, the nurse still can initiate fetal monitoring, but that provider needs to be notified. We've got a patient here and you need to come see her. Period. It's not a Monday through Friday thing either.
And the fetus is going to be monitored if it's, quote, viable.
Right.
So typically, customarily, we're going to be monitoring after about 24 weeks. Sometimes 23 is it's really getting challenging. But between 20 and that's the discretion of the obstetrician. And that's what you guys will work through at your facility, is at what point do we automatically initiate monitoring? Pretty much at 24 plus automatically. Less than 24, that's a conversation institution by institution and involving the patient about viability, but definitely 24 and beyond, assuming nothing else, baby's genetically and physically normal, et cetera. But if you're like in that 20 to 24 week window, we may not be monitoring baby, but we are still monitoring contractions.
Right.
So let's shift to contraction monitoring a little bit, because that's a big part of the evaluation of these patients. So when you're trying to figure out if your patient has an abruption or not, much of the time, they're not going to have any clinical evidence of an abruption. They're not going to have abdominal pain. They're not going to have vaginal bleeding. Their labs are going to be normal, etc. And on ultrasound, only 1 in 5 abruptions is going to be visible. I can't see bleeding on ultrasound unless in certain situations. But so a normal ultrasound does not mean no abruption. It means abruption not visible on ultrasound if present. Okay?
Right.
And abruptions are common in these situations. So we don't have a test that says she's having an abruption. If I see it on ultrasound, she's having vaginal bleeding, she's having vaginal pain, she's having it, or abdominal pain, she's having an abruption. Okay. If I can't see it, she's asymptomatic. It doesn't mean there's not an abruption. So the next step is contraction monitoring. And we need to do a minimum of 4 hours of monitoring as closely related to the trauma as we can. And in that 4-hour period, if she is contracting less frequently than every 15 minutes in all 4 hours of the monitoring, so that's roughly 4 times an hour, she contracts less than 4 times an hour times 4 hours, for all practical purposes, you've excluded an abruption. If you have the opposite, where she's contracting more frequently than every 15 minutes at any portion in those 4 hours of monitoring, she might have an abruption. It doesn't mean she does. And that's where we have to monitor them longer. They stay in the hospital. We do a further evaluation, and our antenna are up. We're looking for clinical evidence. We're looking at the baby. We're looking at mom's situation and deciding, do we think an abruption is likely or not?
Right. So you got to pull threads from different components, right?
Yeah.
You've got to pull the thread from your labs. You got to pull the thread from the ultrasound. You got to pull the thread from the monitoring and critically think, could this patient be having an abruption, depending upon the results of all of those tests. And I want to point out, with uterine activity, there is no one pattern that states this is an abruption.
That's correct.
I think a lot of people always consider, and it's probably because it's been a test question in nursing and medical programs forever. It's probably in a textbook behind me right now that says low amplitude, high frequency uterine contraction pattern is an abruption pattern. And there are plenty of patients who have that uterine activity pattern that, number one, are not abrupting.
Right.
And then there's plenty of patients who are abrupting who do not have that uterine activity pattern. So there's not a specific pattern of uterine activity that should say, okay, we can exclude abruption based upon her uterine activity pattern.
Right.
Doesn't happen.
Right.
So,
it's just uterine activity, period,
right.
or no uterine activity. And the value is in the absence.
Right.
And the other thing to remember is that the farther she gets from the event, the quieter the uterus gets.
Right.
So it's more typical that in the first hour, they may have more contractions, then it just kind of quiets out. But it's contractions more frequently than every 15 minutes at any point in the 4-hour monitoring period. Now, one of the questions that I get asked a lot when I talk on this is, okay, well, what if the patient doesn't come in till the next day?
I was going to ask you that because that happens. I mean, she didn't get taken from the scene, and then she went home, had some contractions, but she felt okay. And then somebody said, you know what, you really should be seen. Why don't you go on in?
Or she has an OB visit, and she's like,
Right.
I'll just mention it to my doc. There is no clear guidance on this. There's no guideline that says this is what you must do. But my opinion and the way I recommend that people handle this situation, as soon as you know about the incident, you evaluate the patient. The same way you would as if she just walked in. For a couple of reasons I say that. Number one, if I do the evaluation and I find contractions, then that increases the likelihood that there really is something going on that deserves further evaluation. If there's nothing going on, it increases the likelihood, like if she's not having an abruption, increases the likelihood that she's going to be monitored for 4 hours and go home. I'm going to know in 4 hours whether or not she needs more care or not.
You're right.
It's not like a huge thing. Okay. She's either going to need more monitoring or she's not. And I'm going to know that within 4 hours. The other thing that I always remember is there is a reason that this patient is telling you about this at this time.
Right.
And I don't ignore that. If she's concerned about it and enough to bring it up in a visit or on a call or whatever, I'm going to do an evaluation. She can decline,
Right.
but I'm going to recommend it.
And I think that's also very true when it may not have been a car accident. Maybe it is intimate partner violence.
Yes.
And now she's coming in, and I would be specifically if the patient keeps coming back.
Yes.
Okay.
Patients don't get clumsy just because they're pregnant. They're not falling left and right just because they're pregnant.
So it's a red flag.
Yes. Big red flag. In other words.
So evaluate for intimate partner violence. And the other consideration is any kind of that frequency at which they're having certain complaints. The other thing that I wanted to make a point of is treat her pain.
Yeah.
A lot of times, again, this may seem minor to us. It may be seeming minor to the ED. If she's complaining of pain, treat her pain as we would if she were injured. She may be injured that we don't know where the injury is occurring. So treat her pain. Anything else you want to include in this, Stephanie? I mean,
I think that one of the other things that is really interesting and clear from the literature is that even in patients who have no clinical evidence of abruption and no real obvious adverse effects from minor trauma, just having a minor traumatic event in pregnancy increases the risk of early birth.
Yes.
So you do have to kind of understand the risk and just be educating and assessing your patients. So these patients need to understand and be educated on signs and symptoms of preterm labor, leakage of fluid, vaginal bleeding, things that need to be evaluated. If you've got a situation where the patient, particularly in motor vehicle crashes where there are opportunities to decrease risk, like seatbelt usage in pregnancy is one of the single best interventions that can be done. And it's a problem in some patients because as you get farther into pregnancy, wearing a seatbelt can be more uncomfortable and it may not stay down below your hips, or below your belly and across your hips like it should be. You need to be having the seatbelt under the belly, across the hip points, between the breasts, not under the shoulder, and airbags and seatbelts are safe in pregnancy and they save lives. They decrease risk, not increase. So, I had one patient, I'll never forget her because she had more than one motor vehicle crash in her pregnancy and would not wear a seatbelt. So I'm like, it didn't happen on my watch, but I was just terrified for the day when this patient was going to come in, seriously injured or worse from a motor vehicle crash that could have been prevented.
Wow. That is scary. I mean, it saved my life. It saved the lives of my two children that were strapped in the middle seat of a brand new Suburban. Saved my husband's life in a rollover accident. Of course, I talked through the entire rollover.
Were you talking or were you thinking it?
No, I was talking.
You were talking.
And my boys remember it.
Really?
I was like doing like my labor coaching. Seriously, I was like, roll with it, hang on. And we were rolling over this whole time, and they were strapped in and we were all safe. There wasn't a window left in our car, including the front windshield, that was intact. And my husband had to be cut out of the car. So we went to the hospital on boards together, and our children did not have to go. But it was,
I'm surprised they didn't take the kids in too.
I know they did not.
Thank goodness.
I tell you, when I saw my friends come down to the ED, to greet me. They didn't know it was me, but when they got there and I saw them, that was the first time that I burst into tears because I thought, my team is here with me. I mean, they were picking glass out of my hair, for hours, but it was so reassuring to know that OB was there and they were taking care of me. So
people you knew and trusted.
Yeah. So once my cervical spine was cleared, no injury, I went up to OB, but they were monitoring me in the ED. I was 28 weeks pregnant.
See, I'd probably be a Suburban customer for life after that.
I know. We did. We
do not make money off of Chevy Suburban, but we would love to.
Yeah, we would love to. It's not a conflict of interest, but yeah, it saved our life and saved the life of my fetus too. But the seatbelt, big time.
I've heard this story before many times, and it just never ceases to amaze me. Like and the fact that you were pregnant at the time.
Like, I know. It is, of course, it would happen to me.
Of course it would, right? There's a comedian, I wish I could remember who it was to give him credit, but I've never forgotten it, where he's like, I don't understand these people that say they want to just be thrown free, that the seatbelt makes their risks higher. And he's like, I think their car, basically when they start their car and if they start driving, with it should just throw them into the windshield to decide if they want to be thrown free, because that's how you're going to get thrown free. You're going to go through the windshield to be thrown free.
I know. I would have gone either through the windshield or out the side window because they were both knocked out. But yeah, it was a scary thing. So I think that's another point, is to realize that the patient and family, once that adrenaline, starts to cease, it's scary all the time, but you're just like, ugh. Yeah. After you realize that what just happened to you.
Shock.
Right? Shock. Yeah, I was in shock.
Yeah, clearly.
No, I tolerated it better than my husband. He was a freak in the ambulance. They were, this is funny, and then we'll end. But they kept saying when they were calling in to the hospital, we've got a, male, blah, 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 and he has movement in his arms and legs, and my husband's arms would go up and start checking to make sure he had feeling in his hands. And I'm like, what are you doing over there? My board's tilted and towards him, and I'm like, what are you doing? Checking to see if you have feeling in your hands?
He was in shock too.
He was in shock. Yeah, totally. But anyway, so that's my story. I'm sticking to it. But anyway, thanks y'all for listening to this episode of our Critical Care Obstetrics podcast. We so appreciate all of our listeners. And don't forget, you can keep learning. You can learn more about trauma specifically from our Critical Care Obstetrics Academy. So in our Advanced Concepts course, we have an entire lecture on trauma in pregnancy and how the differences that you would see in a pregnant patient and some of the management principles that we have for major trauma as well. So, and you can find our courses at clinicalconceptsnob.com. That's our website. And support our mission by joining us on Patreon. Patreon at patreon.com/CCOB is our website for our Patreon, and join our community. You can also watch this episode of our podcast on YouTube. So look up the Critical Care Obstetrics podcast and join our community there on YouTube and watch the video. So make sure you follow us also on all of our social media channels and stay connected. Send us in some topics. We'd love to hear from you. Talk to you soon. Bye.